Good afternoon, sir. Good afternoon, Baluji. Good afternoon, Sam.
Good afternoon.
गुड आफ्टरनून सर, साइंस सर।
गुड आफ्टरनून, क्या हाल चाल है?
ठीक है सर, आपकी आवाज कम आ रही है हल्का।
अब आ रही है?
अभी भी हल्का है।
इससे ज्यादा तेज तो नहीं बोल सकता मैं।
अब आ रही है आप, अभी कम है।
अच्छा, ये अदिति बनर्जी का भी जो है, अपना म्यूट कर लीजिए। अच्छा, अदिति बनर्जी जी का को भी जोड़ लीजिए, वो भी अटेंडिंग में है वो। एक बार हेलो कर देना।
मैं अनम्यूट नहीं कर पाऊंगी खुद को।
नहीं,
गुड आफ्टरनून डॉल्फी। डॉल्फी स्टार्ट कर सकते हैं हम लोग एग्जैक्ट 3।
साहिन भाई बता रहे थे कोई अदिति बनर्जी हैं ट्रेनी लिस्ट में, उस उनको ले आने के लिए पैनल लिस्ट में।
सर 5 मिनट में स्टार्ट कर रहे हैं सर, विद इन 5 मिनट्स वी विल स्टार्ट।
अरे सर, आपको 2 बार बोला जा चुका है कि कोई अदिति बनर्जी हैं पैनलिस्ट।
आवाज क्लियर नहीं आ रही।
आप मैसेज, आप प्लीज चेक योर मैसेज।
हेलो,
मैसेज में आप डालना।
Ji, am I audible to you?
यस वालू, यस वालू।
Okay.
रंजन जी, अदिति बनर्जी को पैनलिस्ट में लाने के लिए रिक्वेस्ट किया गया आपसे।
ठीक है, मैं कर रहा हूँ सर अभी। अभी से कर रहा हूँ। आदित्य बनर्जी कर। और कोई है?
और कोई है ये तो आप ही बता सकते हैं।
अभी मैसेज नहीं आया।
Thank you, sir.
हाय डॉक्टर
Hello,
निधि, हाउ आर यू? हाय अदिति।
hello. Good afternoon, everyone. Good afternoon.
गुड आफ्टरनून।
गुड आफ्टरनून।
गुड आफ्टरनून।
Good afternoon, Shine, sir.
गुड आफ्टरनून।
So it's good to go.
हाँ सर, डॉल्फी स्टार्ट कर सकते हैं।
Yes, sir. So, shall we start?
Yeah, your other panelist Pooja will be joining late, or she has already joined.
Yes, sir. She'll be joining after 3:30.
Okay.
So, right. So, I think we have enough participants. So, shall we go ahead?
Yeah, I think it's time now. We should start well in time and
Right.
finish within the time.
Right, right, sir.
Few more
Right.
students from my
So,
college are joining, sir. So they are actually struggling with the WebEx thing and the old link and the new link. So
Oh,
just a couple of seconds more, couple of
there are
minutes.
two links.
Actually, the previous link was not working due to some reason, so there was another link which was floated. So now that is working.
Okay.
So we have pushed the other link in the system.
right. So, do we wait for them or do we like start and they can, meanwhile, they can
We
join?
can wait for a
can-
few
What-
minutes. Yeah.
We can wait for a
Right.
few minutes. Yeah.
Right, right, for 2-3 minutes. Right.
Meanwhile, you can tell them the process of registration and all.
हाँ
They
जी,
are already
Ranjan ji.
registered, sir. They have been registered from our side, but the thing is they are struggling a bit with the link and things like that.
For rest of the participants, that will be useful if we explain once the
Yes,
process of
we can explain that. True.
Ranjan ji or Balu sir, would you like to do that? Balu sir, Dr. Balu, would you please explain the entire process of registration and enrollment and getting the certificate?
Yeah, thank you so much.
Thank you, sir. Thank you.
A very good afternoon to all the participants. We'll be sharing the link in the chat box. I think you may also receive in your WhatsApp group. I request you to kindly click the link. Once you click the link, it will take you to the NIDM training portal, right? And if you are a new user or a first time attendee of this training program, then you have to create an account by clicking sign in. Sorry. Then once you click that, it will take you to a new window where all your name, email ID, mobile number, and the address to be filled. So once you fill, you have to submit, and after that, the account will be created. One thing you need to keep in your mind when you are creating your password, that should be minimum 8 character, considering one uppercase and lowercase, numeric and special character. So we recommend you to keep your name as a password and first letter into the capital, remaining all small letter, and at the rate of 1. Right. Once you created your account, again come back to the login window, enter your email ID and password. Right. So once you enter and log in, that you have to go to upcoming events, and you will be finding this particular event name. And again, against this event name, right side, you will be finding a green color box where you will be getting an option for enroll yourself. So click enroll now. Once you enroll, you will be receiving a message saying that you are successfully enrolled in this course. You will also receive a mail to confirm that you are enrolled in this course. So I request you to kindly follow all those participants to following this process and register yourself, enroll yourself in this program so that you can get your certificate. So it's a mandatory for registration and enrollment is mandatory for receiving your certificate. So kindly do it, please.
That's
अगर
great.
अभी टाइम है रंजन जी तो हम हिंदी में भी एक बार एक्सप्लेन कर देंगे रंजन जी आप
देते हैं। सबसे पहले हम जो है NIDM के पोर्टल पर जाएंगे, ट्रेनिंग पोर्टल पे। वहाँ पे अपने आप को एक रजिस्ट्रेशन का ऑप्शन है, वहाँ पर क्लिक करके हम उसको ओपन करेंगे तो न्यू रजिस्ट्रेशन का एक परफॉर्मा ओपन होगा। पहले हम उसको फिलअप करेंगे, उसमें नेम और जो भी इंफॉर्मेशन चाहिए उसमें फिलअप करेंगे। उसके बाद उसको हम सबमिट कर देंगे और जो यूजर आईडी और जो पासवर्ड आप उसमें यूज करेंगे उसी यूजर आईडी और पासवर्ड से अगेन हम फिर लॉगिन करेंगे और जो आज का जो सेशन है उस पर हम इनरोल कर लेंगे। तो इस तरह से हम रजिस्ट्रेशन कर सकते हैं।
Okay, good to go.
Yes, sir. Now, sir, Nidhi ma'am.
Please, sir, we can go ahead. I think most of my students have joined. I've got a confirmatory message.
Yeah.
Dolphy, go ahead.
अनम्यूट करो अपने आप को।
Right. So my apologies. Good afternoon to everyone and welcome to our commemorative webinar where we are jointly celebrating the World Mental Health Day, that is today on 10th October. International Day of Girl Child, that is tomorrow, 11th of October, and the International Day for Disaster Risk Reduction, which is on 13th of October. So we are joined together under the joint collaboration of Child-Centric Disaster Risk Reduction, National Institute of Disaster Management, Government of India, International Institute of Health Management and Research, New Delhi, and Child Rights and You. All these three organizations are jointly joint partners for conducting this webinar today. And today we have gathered here to celebrate all of these 3 days. So let me just brief you about what are these 3 days and why is it that we have decided to celebrate them through this event today. So the World Mental Health Day, which is celebrated every year on 10th October, it was formally created by the World Federation of Mental Health in the early 1990s, and it was established to call upon each and every one of us to break the stigma surrounding mental health, to promote awareness, and to provide support for those in distress. And remember that mental health is as essential as physical health. The theme for World Mental Health 2023 is mental health is a universal human right. So from 1990, we have moved towards a universal movement that calls upon mental health to be designated as a universal human right for all. Moving on to the International Day of Girl Child, it was designated by the United Nations General Assembly to be celebrated every year on 11th October. This was done to provide platform to advocate for the full spectrum of girls' rights. And this year the theme is Digital Generation, Our Generation. The theme has been created to highlight to the international community the disadvantages that the girls face online and in the digital space, be it the digital divide, be it the very gender insensitive cyberbullying that they face online, and the over sexualization of females and girl children, especially in the digital space. And moving on to the last but not least, the International Day for Disaster Risk Reduction. Again, this has been designated by the United Nations and is celebrated every year on 13th October. This day highlights the critical importance of reducing the risk and impact of disasters, especially on the vulnerable populations. And a theme for this year is fighting inequality for a resilient future. This theme explores the reciprocal relationship between disasters and inequalities. So now why have we decided to celebrate all these 3 days together and in such a manner is because it is the intersection of these days and their themes. It underscores the interconnectedness of our levels in the field of child-centric, gender-sensitive, disability-inclusive DRR. Mental health support is crucial in times of disasters and crisis, and addressing gender inequality becomes all the more important and fundamental to building resilient societies. And our mandate, the mandate of child-centric and child-led disaster risk reduction, lies exactly at that intersectional space. So with these words, I would like to start the event, and we hope to hear from experts and practitioners who will share their experiences, insights for promoting the themes of the observance days. And I invite you to engage actively, ask as many questions as you can through the chat box and share your remarks and thoughts. And let's hope that we can learn as much as we can through this webinar. So now I open the platform for inauguration, and may I please invite Dr. Kumar Raka, who is the Senior Program Officer of Child-Centric Disaster Risk Reduction Center of NIDM, And just a little brief about him, that he has completed his PhD in sociology from JNU, and he has earned an executive master's in disaster and emergency management from Tel Aviv University, Israel. Sir has been instrumental in establishing the National Disaster Reduction Force, which is the largest and the premier response force, and is recognized across the world for their response efforts and the expertise that they bring to the field. So without further ado, let me invite Dr. Raka to the platform to deliver his inaugural address. Over to you, Dr. Raka.
Thank you very much, Dolphy. I'm audible?
Yes, sir, perfectly audible.
Thank you very much for inviting me in this talk. And like Dolphy told, that this is a very important week, celebrating or commemorating three very important themes. One is on the mental health, the second one is on the girl child, and the third one is International Day for Disaster Reduction. And rightly, all these three things are interlinked, interconnected. First of all, I would like to convey my heartfelt thanks and gratitude to our Executive Director, Sri Rajendra Ratnu IAS, and Professor Santosh Kumar, senior most faculty, now retired, but the brain behind establishment of Child-Centric Disaster Risk Reduction Center. Also, I would like to convey my heartfelt thanks to IIHMR and specifically Dr. Nidhi here, who has been one of our colleagues since long, Dr. Sahin Ansari, Aditi Banerjee from CRI. They are representing CRI. The CRI is another of our partner in celebrating this, commemorating this special days through this webinar. I would like to just tell a few things. 10th October, 11th October, and 13th October. Normally, like Dolphy told, that this year the theme of World Mental Health Day is that make mental health universal human rights. And same with the girl child also. It's very, very important that we have to provide a special focus on inclusive growth and development of girl child. Otherwise, the way the society is dealing with gender inequality, that cannot be addressed. And same, when we are discussing about normal things in normal situation, the importance of mental health is there. If the mental health is not fine, then definitely the physical health is also affected by that. And the girl child, the gender inequality in society, and at the times of disasters and emergencies, all these things get accentuated and reach at its highest level, whether it's the issue of mental health or the gender inequality in the society. And that is how CCDRR Center and IDM thought that, okay, let's, this is a special week, three important issues are here. Why not to talk with our audience and discussing all these three important issues on a single platform. And as you know that October 10, it's the World Mental Health Day, and it's about to raise awareness about mental health around the world and to mobilize efforts to support those experiencing mental health issues. And you will be surprised to know, I'll give you some more data and something like that. 33 to 90% world population is supposed to be affected by mental health issues somewhere. Okay. So in any society, any place, if we are counting 100 people, at least 33% and at the most 90% people are affected by mental health issues. This is the one thing. And the second thing, earlier it was a big taboo that we didn't want to discuss about mental health issues with our colleagues, with our friends, and within the families also. The actually the awareness was not at that level, that if something is going on, the parents also used to think that okay, this is something that will go ahead with the time, that will vanish on its own, but it's really not. Every year since and understanding the stigma what society was having, understanding the importance of mental health issues in the society, the every year the World Health Organization started the global campaign for World Mental Health Day, and the World Federation for Mental Health announced theme for this year, that make mental health universal human rights. And it emphasizes the necessity of assuring that everyone, regardless of their age, socioeconomic structure, class, or the background, should have access to a high quality mental health care and support. But things are very good, but reality is far, far away if we go through the Indian context or the Indian society. If I remember exactly, I don't remember the exact numbers, but the medical doctors per thousand population, the number, and if you go through the counselors or mental health experts per thousand population, there is a huge gap in between, and that we have to address. According to World Health Organization, you know that half of all mental health issues begin before the age of 14 years. Before the age of 14 years. However, the majority of incidents, like I told you, that people are not aware, the mental health is a taboo in society. The majority of incidents go unnoticed and untreated. Adolescents and young adults are one of the group that frequently encounter challenges and also struggles to receive mental health care. If ignored, what generally it's ignored in the society. If ignored, these mental health issues affect their day-to-day activities, careers, entire personality, and their future while they are growing up. Lack of awareness and the stigma around mental health issues can make it hard to communicate their distress. Therefore, in-house counseling at campus, educational institutions, programs, workshop, or other methods can help empower the youth and adolescents. They should talk about their mental health situations, issues. Many teenagers and young adults also feel pressure to perform well in school. That is our society. Everyone is after why you are not getting 99%, why you are just stuck with 90% of the marks, why your grade is deteriorated. So there are a lot of pressures, from peer pressure is there, teachers pressure is there, parents pressure is there. And in addition to that, the youths and adolescents and children, they could have to deal with the competitiveness along with the influence on the social media. Today, social media is a very strong issue now. How many likes I am getting, how many comments I am getting, that is another stigma what our youths are facing, the children are facing. And all these factors can affect adversely their mental health conditions, their motivations, and their self-worth. The stigma around mental health issues and seeking help for the same is universal. It restricts individuals from expressing their concerns as well. Therefore, as a society, it is crucial to have resources that can help one take care of their mental health properly. Many parents and guardians do not take their adolescents and young adult children mental health problems seriously. They just write it off, okay, this is normal or temporary, this will go away. The young population in India require extra care and support for their mental health for a variety of reasons. Every age group needs to learn more about mental health. It can help create a positive environment in the society as a whole. It is crucial to create an environment that is safe and encourage individuals to talk about their mental health. The provision of accessible and inexpensive mental health treatments such as peer support, therapy, medications, and counselings can be very impactful if the problem we can identify at the right time and it's treated well in the time. Otherwise, like I told you, 14 years age, young adults, very young children, mental health issues are there, not treated on the time. It becomes ASR, ASD, and after that, chronic PTSD. And once it's into the phase of chronic PTSD, post-traumatic stress disorder, then it's very, very difficult to treat it, even with clinical interventions. The best thing is that children as well as the young adults should be given the chance to express themselves, make choices, follow their passion, and realize their objectives. Additionally, they should also be helped to manage stress and challenges. And for that, not only parents, not only teachers, but the society's contribution is very, very important. The peers, the friends groups contribution is very, very important. Now coming to the next important point, the International Day of Girl Child. Like Dolphy, while making the background, putting the background of this webinar, already told that why the International Day for Girl Child, annually observed on 11th October every year. And it provides a global platform to advocate the full spectrum of girls' rights. And at a time when we are seeing a range of movements and actions to curtail girls' and women's rights and roll back progress on gender equality, we see particularly harsh impacts on the girls. And that becomes much, much more evident and stressful in the times of disasters and emergency. Either it's maternal health care or parenting support for adolescent mothers, or the digital life, or the life skills training, or the comprehensive sexuality education, or the violence inside home, domestic violence we talk about, or the workplace violence we talk about. There are various kinds of violences, mental violence, physical violence. And that is why there is an urgent need for an increased attention and resourcing for the key areas that enables girls to realize their rights and achieve their full potential. Responding to girls' calls for change, the global community must move beyond reaffirming commitments and invest boldly in the action needed to make that change. When we pay attention, we see that already many girls are championing solutions and changing their communities. But until unless a proper support from the communities, the societies, the families, the structures are not provided, then fighting alone is there. Together with our government and civil society partners, we can create a world where girls have a space to shape government policy and spending, to inform the rules and norms by which businesses should operate, and to direct the priorities for new research and innovation. Already, Dolphy told about that all like-minded partners must center girls' right in their work to tackle the pushback against gender equality, whether it is maternal health care, parenting support, unpaid care work, or access to financial literacy and resources. Adolescent girls tend to be sidelined. Recognizing, celebrating, and supporting girls' leadership, that is also our Honorable Prime Minister's 10-point agenda, that women leadership into the DRR. So on the one hand, it's the International Day for DRR, and on the other day, just a day before, it's International Day for the Girl Child. So this is the best week where we can take a place that we will take care, we will support the girls' initiatives, we will provide a very safe and conducive environment for their progress, for their growth, for their leadership. And definitely girls' leadership is something that, without creating space and platform for girls to raise their voice at every level of policy making, and directly resourcing girls' movements and networks, and centering girls' voices, agencies, and leadership in all programs, it won't be possible. And for that, not only government, civil society organizations, along with the communities, are crucial. Introducing and scaling up multi-sectoral programs that support adolescent girls' well-being, and ensuring information, services, and systems meaningfully to change to be adolescent girl friendly. This includes tackling the stigma and poor treatment many adolescent girls have highlighted in accessing the essential services. such as sexual or reproductive health services, coming to school if pregnant or having given birth, or in managing menstrual health or hygiene. It's everywhere. There are problems, but structural, we have to find out the root cause. What is the problem? And until unless the sense of equality is started being provided from the very young age, within the family, within the schools, within the learning opportunities, we will just keep celebrating the empowerment of girls and we'll talk about women leadership, but that will be very, very difficult to achieve. The next one, the International Day of DRR. NIDM is, let me inform all of you that NIDM is already going to commemorate it on 30th of October, face to face, and we are planning to, we are just organizing, not planning now, it's being organized on a larger scale. And this International Day of Disaster Risk Reduction, we all have to come together to recognize the importance of disaster resilience and our collective responsibility to reduce disaster risk worldwide. Recently, we have seen within the country also Himachal floods, before that Turkey earthquake. Recently, Nepal also jolted. Delhi, all you people are living in Delhi, you must have felt the tremors. And something if happens and after that there is chaos. But before that, we have to understand, see, we have to stop turning hazards into the disasters. And for that, we have to just focus on the exposure and vulnerability. Until unless we think about what is vulnerability, what is exposure, and how risk is being increased or how the risk is being decreased, talking about DRR is again useless. Today, we are celebrating our global efforts to reduce disaster risk. Commemorating this day every October 30th, it underscores our commitment to safeguarding lives and communities from disasters. In the year 2023, our focus is on the reciprocal relationship between disasters and inequalities. Now, see, when we are talking about gender also, we are talking about inequality. And here also, disasters are very gender neutral, okay? An earthquake is not saying that I'm going to affect a man or woman. A flood is not seeing that, okay, I'm going to affect only man or only females. But the impact of disasters are never gender neutral. If two kids are living in the same households, take the example of COVID-19. If the family income was reduced, who was the first one to be dropped out from the school? If we compare between a boy and a girl about a particular socioeconomically weaker background family, definitely the girl is the first one. Okay, limited resources. So who is going to study in the school? The male. The male child is going to school, and the girl child is dropout. So disasters are always gender neutral, but their impacts are not. And when we are talking about the impact of the disaster, it's already, there are socio-economic inequality, gender inequalities already deeply rooted into the society, and that comes at the forefront after any chaos. That is as simple as poverty, inequality, uh, discrimination are causes and consequences of growing disaster risk. Inequality creates the condition that render people exposed and vulnerable to disasters. Disasters also disappropriately impact the poorest and most at-risk people, thus worsening inequality. Reducing vulnerability to disasters requires addressing these dimensions. Otherwise, very difficult to stop turning hazards into disasters. By the year 2030, there are some estimates that current climatic projections, the world will face around 560 disasters per year. An additional estimate 37.6 million people will be living in condition of extreme poverty due to the impacts of climate change and disasters by year 2030. And a worst case scenario of climate change and disaster, that is saying that will push an additional 100.7 million people into the poverty by 2030. We can curb all these destructive powers of hazards. In other words, if we stop them from turning into disasters, and if we want to stop converting a hazard into the disaster, then we have to be very careful, and a coordinated planning that should be designed to reduce the people's exposure and vulnerability to the risk or harm. Greater investments are needed in the collection and the use of disaggregated data, both to better understand disappropriate disaster impact and exposures and to inform resilience building plannings. Disaster management is always a shared responsibility. We used to say, again, not only NDRF, not only NIDM or NDMA, they cannot make a disaster resilient country unless the support from the communities, the individuals, and everyone else. Disaster management is everyone's business. Every individual and community must actively engage in disaster risk reduction efforts to protect lives and enhance resilience. As we mark these 3 important days this week, 10th, Mental Health Day, 11th, International Day for Girl Child, and 13th, International Day for DRR, let us remember that our actions today will shape our resilience for tomorrow. Together, we can reduce disaster risks, bridge inequalities, we can make mental health issues an universal right, and create a safer world for all of us. Thank you very much with these words. And once again, I would like to thank all my colleagues here, Dr. Balu, Ranjan, Nazia, Sahin Bhai, Aditi, Dolphy. Nazia is always faceless. And all of you participants who has been gathered here. And it will be very, very interesting listening to experts today. Nidhi Yadav is here, and ma'am will be joining, Pooja ma'am will be joining in a while. So over to you, Dolphy. Thank you very much.
Thank you so much, Dr. Raka, for setting the tone of the day. And now may I please invite Ms. Aditi Banerjee from Child Rights and New Cry to deliver her special address for the day. So before that, just let me just introduce her to the participants.
Pooja is already here. Ranjanji, can you bring Pooja to
the panelists?
She has already joined.
Okay, okay, ma'am.
Right. So as I was introducing Aditi, she is currently working as a policy consultant with CRY. She has done her post-graduation in sociology from JNU, New Delhi, and she has almost 9 years of experience in the development sector, wherein she has primarily worked with children and adolescents with respect to various issues ranging sexual and reproductive health and rights, inclusion, menstrual health, and mental health. And some of the organizations that she has worked with are UNICEF, NCERT, and Smile Foundation. So welcome Aditi to the platform. Now the floor is all yours for the special address. Over to you.
Thank you, Dolphy. सभी को मेरा नमस्कार. Dr. Kumar Raka, Dr. Nidhi Yadav, Dr. Balu, Ranjan ji, Nazia, Shaheen ji. A very good afternoon to all of you. It is indeed a matter of pride and honor for me that I am, given this opportunity to give the special address for this session. Fortunately, unfortunately, I don't know, whatever I had planned to say, Dolphy and Dr. Raka has already said, so it's going to be a difficult task for me. But nonetheless, I'll try my level best to sort of bring in some new perspective into the already, stimulating engagement that we are going to have, or we have already started. So today indeed is a very special day for all of us because we are celebrating the World Mental Health Day. So when I was being told that I have to, do the opening address, I was constantly thinking, how should I start? Or, what should be my approach for this? So I kind of revisited the webinar poster and I kind of picked out the 3 keywords that I could locate. The first was World Mental Health Day, second was International Girl Child Day, and the third was International day of DRR. And I was trying to understand how or in what way can I relate the three things together. And after a lot of thinking, observing, and a bit of reading, I realized that these three pillars are actually intrinsically interwoven with each other. We cannot talk about mental health without considering girl children, especially in a disaster situation. If we are talking about a disaster situation, we will have to talk about mental health. We will have to sort of devise and design projects that specifically focus on the girl child, given the social fabric that we have for the society. That is something, since I'm representing an organization which primarily works for the best interest of the children, we also have to understand that here we are not talking about children as only recipients, but we are also talking about children as active change makers and active participants in driving change. So when we say that mental health, raising awareness, or mobilizing support or bringing in a collective effort, that is definitely important. But also one of the important debates that are emerging in the contemporary time is how mental health has to be affordable and accessible. There is still a lot of people who might be aware that they are not doing too well in terms of their mental health, but they do not have the capacity or the resource to sort of access, mental health support. So that is one thing that we need to think about. Secondly is the involvement of different stakeholders at multiple levels. As Dr. Raka has already mentioned, community plays a very important role. We at times think that, oh, it's only the policy makers or probably the officials or the bureaucrats who are doing everything. But if we think that, we are undermining the potent tool of change, which is the community, because community has the capacity to actually build a safe net and a safe ecosystem, not only for the children, but for everyone, especially in the context of a disaster. As Dr. Raka has already mentioned, there is no gender for a disaster. When a disaster strikes, each and everyone, irrespective of their gender, gets affected. However, given the context, girls or females are at a higher risk of a lot of things. Child trafficking, is at a high when there is a particular disaster. Child marriage, child labor, all of these social evils which obstructs the growth of a child is at high. During COVID-19, there were innumerable number of researches that has been done, and we found out that there was a massive dropout of girl children from the education ecosystem. There was a drastic rise in the levels of child labor, because they had to fend for their families, there were no employment, and they had to be be at the role of earning the bread for the family. Now when we talk about a resilient future, resilience can only be built if we have the resources around us, if we have the conducive environment to build our resilience. For a child, if we say, oh, that you have to be resilient, then we'll have to ensure that we are providing that child with that conducive environment or the right sort of life skills, which makes the child resilient. Because if the child is not resilient today, or if he or she is not getting the important resources that is needed for him or her to be resilient, then we really have to review and rethink that whether the future can be resilient or not. That is one thing. Also, as I have already talked about access, now I will be going on to talk about participation. Now, when I talk about participation, it is not only involving children into discussions, but rather it should be children-led collectives. What the children feel. We cannot be sitting at a position of an adult and decide for the children, oh, this is something that the children might want. We will have to give the leadership to the children. We'll have to make them capacitated enough wherein they can lead the collective through their own decisions, through their own understanding, and through their own wisdom. Also, I read somewhere that absence of mental illness doesn't mean that you have good mental well-being. If you say that, oh, I don't have this particular mental illness, it doesn't mean that you have a good mental well-being. Doesn't necessarily mean that. So we always have to sort of think from that perspective. mental health talks need to be organized at multiple levels, not only at the clinics or not only at the psychiatric centers or anything. It has to be introduced at the very basic level. It has to be introduced at the school levels, wherein teachers can play a very important role. The SMCs can play a very important role to understand that why mental health is important. When we see it from the perspective of the girl children, we'll have to see that a lot of girls drop out from school wherein there are no functional toilets, because when they start menstruating, they go to school, they don't find toilets, they are embarrassed, and that has a lingering effect of stress and anxiety amongst the girl. And they find it better that if I drop out from school, I will not have to feel scared that, oh, somebody might know that I'm menstruating, I might stain my clothes. There can be cases of embarrassment. So these are little things, but if it is being ensured at that very level, at the very beginning, it can have a long lasting effect on the life of the child. Also, we are talking about inequality and fighting inequality. So inequality is at a different level. There is institutionalized inequality, there are social capital inequality, and inequality at different levels. So when it comes to girl children and mental health access, there is also a need to address that mental blockage when it comes to addressing the mental health issues of a girl child. Because the first thinking that comes to a parent's mind is, oh, agar pata lag gaya ki meri beti psychiatrist ke paas ja rahi hai ya wo therapy dikha rahi hai, to shayad usse koi shaadi nahi karega. These are mental blockages that exist because there is a still lot of stigma attached to it, and we are not able to sort of address those stigmas. So there could be various ways through which these stigmas and these myths could be addressed. For example, CRY recently, is in the process of creating a mental health consortium wherein we have invited, experts from all over India to sort of deliberate upon the Mental Health Care Act 2017. And we are trying to strengthen that existing act from the perspective of child rights. How the perspective of the child rights can actually make a very long lasting impact, not only at the level of the act, but also at the level of the policy, how it will trickle down to the strategy, and eventually at the level of implementation. I think with that, I would like to thank everyone again. And I think I have helped in contributing in the conversation that we are having. Over to you, Dolphy. Thank you so much.
Thank you so much, Aditi, and thank you for highlighting the very, very important factors, especially with respect to affordability in mental health care, and then talking about the menstrual health management for girls, which we know is a very, very important factor in their overall physical and mental well-being. So thank you so much. And now may I start the technical sessions of today with Dr. Nidhi Yadav from International Institute of Health Management and Research. So before I introduce ma'am to the participants, so my request to the participants is that we want to keep this webinar, this day very, very interactive. So I would request all the participants to write their questions or their remarks or any experience that they might have with any of the themes in the chat box, so that we can create this interactive experience, I mean, as much as we can virtually, right, without creating a lot of chaos. So my request to the participants to interact with us through the chat box, right? Yes. So introduction to Dr. Nidhi is that she's a doctorate in hospital management with specialization in disaster management. She holds masters in hospital management with specialization in quality management from the Indian Institute of Health Management and Research, Jaipur, along with the dual masters in business administration from Punjab Technical University. She's currently working with IIHMR as associate professor, and she has experience of more than 13 years in hospital operations and quality management. She is a seasoned academician, researcher, and medical quality administrator with the zeal to bring tangible changes in the way quality and disaster management is perceived and practiced in the healthcare industry. And I was, just before the webinar talking to Dr. Nidhi, and she has been doing very, very interesting work with respect to, youth-oriented, child-centric disaster risk reduction. And we are very excited to hear from her. And over to you, Dr. Nidhi. You may please start with your session.
Thank you, Dolphy. Thank you for those kind words, first of all. And very good afternoon, Dr. Raka, Dr. Balu, Dr. Ranjan, Shaheen sir, Aditi. And thanks a lot for setting the tone. Thanks a lot for having me here also. And thanks a lot for having my students as well here. They are really excited to show their work and write their experiences in the chat box, if you don't mind, because they have been working for last 10 days in the field for delivering the disaster risk reduction events, sensitization events, trainings events, hands-on poster making with various stratas of community, starting from refugees to slum children to college goers to school goers to rickshawalas to autowalas to, I just read that thing. And if you don't mind, they can share their experiences in the chat box, because that's actually youth-led DRR, which Dr. Raka promotes very strongly in all his talks, and it has to reach the audience, which is the general population, because sitting in the room we all can discuss a lot of things and we can at least be heard by the policymakers, but when it trickles down from policymakers to down the line, it has to reach the common man, the consumer of those policies, and that is the one who suffers from the disaster the most. And the students at IHMR, thank you for having us here, the IHMR as an academic partner for this program. And we are actually
ma'am, may I
leading the
please,
show.
I apologize for interrupting. Thank you for asking your students to put up their experiences. What we can do is they can write their experiences in the chat box, and we can document them. So that will be really great. We can document those experiences as part of the report. So that will be great.
Exactly. So I request all the students of IHMR who have joined, kindly put up your experiences very lucidly in the chat box, as Dolphy has said. So my presentation or my talk is actually on youth-led DRR, because I am a strong advocate what Dr. Raka promotes, and I completely echo with his thoughts. And youth, until the agenda is on the plate of the youth, it does not become the national agenda, because youth is approximately 30 to 35% of our total population as of now. So until the idea clicks to the youth and is on the shoulder of the youth, you really cannot make that thing materialize on the ground in society. So with that note, and with my students on board, and with my friends like Dr. Ranjan, Dr. Balu, Nazia, Dr. Shaheen, and Dr. Raka as my guide and mentor, I want to start the presentation by sharing it. Thank you. Yeah. So is the screen visible?
Yes, ma'am. Yes,
All
it's
right.
visible.
All right. So the title, as it says, youth-led disaster risk reduction, and the target audience or my focus group was for vulnerable children. So why do we have to do that at all? Why do we have to look for vulnerable children only, and why youth, that I already explained? So the slide is not changing.
Ma'am, sometimes it happens with WebEx. So you might want to use the arrow that's there. Click on the arrow that's on the bottom left part of the slideshow.
I see. Did the slide change now?
Yes, ma'am.
All
So
right.
over here you will
Thank you.
find in the slideshow you'll find on the bottom left. Yes.
Yeah,
So you
I
can
could get
use
it
that.
now. Yes. Yeah. So we need to ensure that our future is in good hands. We all do investments according to that. We all plan our future according to that, and we want our future to be really safe and secure. So how do we do that? Youth represents half of the world population if children are included into it, and they represent, when I talk of youth, I talk of people under 30 years of age, and they benefit most from the disaster risk reducing activities, and they are the worst hit at the time of disasters, and they are hardest hit also. in terms of child and youth experiencing disproportionately large amount of physical, mental health issues, nutritional need related issues, access to education, economic opportunities, exposure to violence, and many other limiting factors on their side. They are the worst hit population, and being the largest part of the population, their agony, their problems create a lot of impact, a rolling stone effect in the society. So children and youth specifically living in poverty and other vulnerable situations face even bigger risk, especially as climate change increases in magnitude and number of disasters around the world increases. Dr. Raka mentioned that approximately 560 disasters per year will be seen by the end of this decade, and that seems so true as per the even if there are estimates that seems so true with the number of extreme events increasing day by day. And it is also mentioned in the Sendai framework, if I have to say, that Sendai framework for disaster risk reduction very clearly states that children and young people are agents of change and must be given the space and modalities to contribute to DRR in accordance with legislation, national practices, and educational curriculum. So no one has to be left behind. No one has to be secluded. No one has to be treated as a second to somebody or some recipient group. So inclusive policies, acceptable policies have to be on the agenda, national agenda, legislative agenda, etc., and even educational curriculum. So actions which becomes all the more necessary, considering that all the actions that I'm going to talk about, I'm trying to say, all the actions become all the more necessary considering that children and young people are among the most vulnerable groups as well in the face of a disaster. According to a study by the Economic Commission for Latin America and the Caribbean, disasters will impact approximately 175 million children per year by the end of this decade. So we can see the amount of impact that is going to happen, the number of people that are going to suffer, and especially the number of children that are going to suffer from those disasters. The culture of disaster resilience need to be inculcated among children and young people through collaborative means with civil societies, academia, government and non-government institutions, along with media. That is my I want to set the tone on these lines, that we need to rope in that 1/3 of our population to serve the other 1/3 of the population, and empower half of our population using the various means, various mechanisms, various institutional methods, and bring everybody on board to have population resilience toward disasters and achieve the maximum goal out of it. So why children uniquely? How does the disasters and emergencies affect children uniquely, and why do they need special attention besides the youth? Children's have different body structure. They consume more air per pound of their body weight, so they have different needs. They have thinner skin, so they are their surface to mass ratio is higher as compared to adults. They have less fluids in their body, so fluid loss at any level due to dehydration, maybe because of a heat stroke, or dehydration, or blood loss, or massive blood loss rather, can have a much bigger effect on children as compared to an adult. So they are more likely to lose body heat. They generally spend more time outside. They generally put things in their mouth. So they have the behavioral issues, they have their physiological issues and the psychological issues, which are unique characteristics for their age specific needs. And they have difficulty in communicating their needs as well. That's another setback to them. A young child might freeze or cry or scream or go into a hysteria in the event of a disaster, as compared to an adult who may ask for help or try to explain his situation by means of words. So that limitation of expressing themselves also makes them extremely vulnerable. So, and mental stress, from disasters can be harder for children to absorb, acclimatize, adjust, rehabilitate themselves. So the range of children is very limited as compared to the adults when it comes to resilience towards disasters. And otherwise, children are extremely in a stressful situation when they are affected by the disaster as compared to their counterpart. There are so many studies to substantiate what I'm saying. So the children specifically are with all these unique features and factors make children more vulnerable. And imagine if a child is living with all these vulnerabilities, physiological vulnerabilities, if he's living under extreme conditions like poverty, social discrimination, their families living under slums, or in refugee camps, which are already compromised in several ways. And if the child is suffering from one or the combination of disabilities, imagine a disabled child living in slums or in poverty, then the situation becomes more grim for the child as well as the family. So the impact exponentially increases as the situation gets complicated because of the living conditions. Looking at the magnitude of problem, which is already spoken by many experts before me, Dr. Raka already spoke about it, Aditi spoke about it. Let me just touch base upon it. Worldwide there are approximately 2.2 billion people under the age of 18 who can be called as child. And in 2014, approximately 90 lakh girls and boys dropped out because of this of school for various reasons. And 30 to 50% fatalities in natural disasters are seen for children specifically. Be it any event, any disastrous event, 30 to 50% fatalities are seen among the children. And as on date, 1 in 4 children is living in a country affected by conflict or disaster at any given point of time. So this is the cross-sectional as well as longitudinal presentation of the magnitude of problem that we suffer from. And humanitarian crisis, if we talk not only about disasters, but my talk is also covering the sufferers of humanitarian crisis, the situation becomes more complex, it becomes more frequent and persistent. Right now, while we are in this talk and we are discussing the child-related issues, the Palestine-Israel conflict is going on in the other part of the world, and we will see many more casualties, many more sufferings, many more exodus, movement of migratory population with children, women, and other disabled, people very soon in the reports, the reports which will cover this issue. So why children dependency on the is a factor beyond health? Children, they actually have access, they need access to food, clean water, shelter, housing, and education. But their dependency on the adult makes it inaccessible. They really cannot go out and ask for food, clean water, shelter on their own. So their dependency on any adult or a caregiver of their family member or the family member makes them more vulnerable, and that increases their needs beyond the health needs. The basic and essential care for newborn from this entire group of children, which ranges from anybody who is less than 18. If the child happens to be a newborn, then the situation magnifies. Situation becomes even more grim because the child is dependent solely on the mother for the feed, and mother is in the crisis situation herself. So it becomes a exponential and a very grave situation. Then high risk of disease and malnutrition among the children who are in the compromised situation of poverty, socioeconomic, this thing, problems, disability, or any other situation which compromises their needs for nutrition and puts them at risk to various diseases. Then comes the group which is adolescent, that is post-puberty group, which is still not mature enough to handle the situation, but is not young enough to not able to communicate themselves. So that fine line of being an adult at the same time, but being hit by the emotional and hormonal influxes actually make them more vulnerable, not only to their own mental crisis, emotional crisis, but also the sexual violence and abuse that they go through in the crisis situation. Disaster actually brings a lot of crisis situations along with themselves, which includes sexual abuse to the max, be it home-based violence or gender-based violence in the crisis situation like COVID, which we have seen, or in the migratory population, or in the refugee population, or in any other type of disaster, migrations, child trafficking, women trafficking, sexual abuse, all these malpractices hit the situation very hard, and they hit the women and children very hard. And boys are no less sufferer. Let me tell you, this problem, this menace is irrespective of the gender of the other person. So boys and girls, women and men, both are equally affected if they are vulnerable in the crisis situation. And in case if the disaster is up, it leads to closure of health facilities and shortages of health professionals due to one or the other reasons. They are, posted at some other places, or they are sent to other places for crisis management, it becomes even more grave. And causes for mortality in children are usually the same as conditions that causes mortality, morbidity, or mortality non-emergency situation. So anything which is a non-emergency situation for a normal condition, or the normal ongoing crisis, normal ongoing condition, can become a crisis if it is a child. So you can imagine a child in a normal non-emergency condition, if he goes untreated or unnoticed, may become a disaster, individual level disaster situation for that child. So now the question arises, is every child, each and every child that we are covering right now or trying to cover right now, is equally affected by the disasters? I don't think so, and nobody should think like that. Every child has a different need, every crisis situation has a different need, every background that we talk about, every condition of the family, condition of the society, condition of the country, legislative situation in the country, everything weaved together makes the child unequally vulnerable, or it affects the children unequally across the spectrum. So exposure to other forms of violence or trauma after disaster varies from situation to situation, location to location, variety, etc. And they are exposed to multiple potentially life-threatening disasters basis the hazard profile of the their area, their geographical area. So that also varies. Somewhere the flood hits hard, somewhere landslide and earthquake hits hard, somewhere humanitarian crisis hit hard, somewhere traveling hits hard, somewhere drought hits hard. So it, as the crisis situation, as the type of crisis varies, so is the effect on the child. And those who felt their life was in danger during the disaster event also vary. Some children who are living in a country where they are disaster prepared, they are given the basic training or understanding about the crisis situation and things, their response to the trauma or response to the traumatic situation varies, and they were found better prepared mentally, physically, socially, in terms of the equipment and other resources, as compared to the children who are in less resourceful conditions. So it varies when the child is in the danger at different conditions and at different situations in the life. And several children have experienced multiple stressors in the recovery period as well. Expression being one of them. Children find it very difficult to express their experiences during the crisis situation, which make them even more vulnerable in terms of the rehabilitation or the health seeking behavior for the child. It becomes difficult to provide health care to that child, mental health, physical health, or emotional health crisis that the children suffers. The number of missed school days varies from child to child, condition to condition, and disaster to disaster. So that also unequally affect the children in crisis. And if the child is a member of unreserved or marginalized group, that becomes another paranoid like of kind of situation, where if the child belongs to an unreserved group or marginalized group, or a group which has special needs, then it becomes really difficult, and the effect of crisis or the disaster is unequal on those children. Now, what are the health risks that children could face during the situation? So why I'm trying to cover all these things is I want to set the tone that when we address the disaster risk using our youth into disaster risk reduction related activities, all these basic premises were considered, all these basic premises were taken into account while planning the programs, planning the events and targeted activities. So various health risks that face the children include communicable diseases, vector-borne diseases, neonatal causes, malnutrition, micronutrient deficiencies, injuries because of the said disasters, and lastly the emotional impact, which should not be neglected when we are standing in 2023 and talking about mental health day. And this emotional impact varies from gender to gender, women as well as men, children, same ways. The female child and the male child suffers differently many a times basis their overall crisis situation. Some other challenges, if I may talk about, includes children with disability or some children with special needs. For example, locomotor disability, for instance, mental retardation, for example, cerebral palsy, for example, multiple disorders, for example, visual impairment, hard of hearing. So these special needs add on to the challenges for a child. Then availability of emergency resources that makes it completely different for a child who is in a crisis situation, coupled with a sort of disability, coupled with socioeconomic crisis, coupled with poverty, coupled with lack of education. All these things, when these things are put together, they have a dramatic and exponential effect on the overall outcome of the crisis for that particular child. Then the economic, geographic, racial, ethnic disparity in the community puts the child differently to the crisis situation, and the way they manage the crisis situation and finally comes out of it, that is rehabilitation. So children accompanying migratory groups, especially the refugees, if you go to them and talk to them and try to deliver any care or any sort of support or any sort of sensitization program, you will find their needs totally different, their aspects, their outlook, their acceptance to the the care provider or to the sensitization person, completely different to the one in the other situations who belongs to a community or has a referral group with them. And then children residing in slum, both urban and rural slums, irrespective of the level of difficulties that they face otherwise in the society, living in the slums put them at an additional risk of a disaster to them, especially related to diseases, communicable diseases, sexual abuses, alcohol abuse, and substance abuse, and things like that, which are otherwise prevalent in the society, but children were saved from that because of a strong family, strong social network. But slum children are specifically vulnerable and exposed to these kind of additional problems as well, which make them supremely vulnerable to additional disasters. So what do we do next with this background, with these problems, with these challenges, with this sort of scenario that is facing us world over, especially in the developing countries? In 2023, when we are saying we are so advanced, we can send Chandrayaan 3 mission, Aditya 1 mission, and all other sort of space missions. So where do we see our children, our vulnerable children, especially girl child, if she is on the target, where do we see her? So inclusivity is, of course, the theme or the backbone of all the programs that run across the country. But who has to be inclusive and by whom? So if we give this responsibility, or if we have the youth shoulder the responsibility of taking the lead forward and empower our youth into that, then it becomes a national program, because youth is our biggest strength, biggest number, biggest strength. So youth-led DRR initiatives that we conducted, if I can vouch for my institution, that is International Institute for IHMR, and the master students and the research officers which led this program, the target audience for us was the public health infrastructure, like health and wellness centers of Government of India, the primary health centers, the district hospitals, school students in various normal schools, from kindergarten to high school, then graduate students in various colleges of India, then children with disabilities studying in various special schools, underprivileged children studying in various special schools and residing in slums, then children from the refugee camps, then the street plays were used for accessing or imparting information to the vendors, to the hawkers, to the autowalas, to the rickshawalas, the unprivileged groups in open markets and streets and parks, etc. So the youth-led DRR program actually looked at the preparedness for emergencies. Then what emergency response are we going to deliver in case we are hit by any sort of emergency? For example, a smallest one, say, road traffic accident. What are you going to do? A small fire incident in your school, for instance, a small building collapse in your area because it was an old building. For example, how do you hide under the table in case of earthquake? So all these things, and especially, and the focus for the graduates and postgraduates level population for us was disaster specific acute care management. So targeted plans, targeted events were curated against this population, with special focus on the vulnerable groups, including children. And last but not the least, the emotional care, that what do we do before, during, and after disaster or any traumatic event that we come across, that was looked at very closely, and it was weaved into the program so that at the end of it, the emotional care, emotional support can be delivered to the affected population by the immediate care provider, who is our own neighbor, or maybe our own family member, maybe our own colleague when we are at work, and things like that. So this is a glimpse of the DRR activities that we have conducted across India, and we could do it in 11 states of India through various means, by physically visiting the place or getting them online on an online platform and delivering a talk, or being available, hand holding them, and making the stuff for them and getting the things delivered. This is a small glimpse of that thing. So and this is the footprint that we could do, from starting from graduate institutes to refugee camps at Signature Bridge, to the special schools, to the normal schools of toddlers, to the special forces group, NDRF, and to various districts of Chhattisgarh, Raipur, to the transgenders, in West Bengal, to starting from all the public health infrastructure, primary health centers, etc. So this is the pan India footprint of approximately 11 states that we could reach in our program for the last 10 days, and all run by the efficient student group and the research officers at the institution. So I have a few video presentations of 2 to 3 minutes, 2 to 3 minutes and I have kept only for the special population, persons with disability, refugee camps, and privileged children, underprivileged children group. So I would just like to run through these a couple of presentations in quickly, so that you can have a look at what impact, what we did and what impact it brought. Just a glimpse of it. Okay.
Disasters undermine the lives of those most at risk. People with disabilities are often disproportionately affected by disasters.
You can either share the screen, or if it is in a browser, you can share the browser, or you can share the video through both audio and visual.
यार करना इसको कैसे करना है? How do I do this?
Ma'am, if you go to share, what you can do is, if you go to share.
Okay, yeah, got it. Sorry.
Yeah.
Is it now? Could you see the video?
Yes. Right.
Disasters undermine the lives of those most at risk. People with disabilities are often disproportionately affected by disasters and have different and uneven levels of resilience and capacity to recover. Many are socially or logistically isolated and lack access to evacuation warnings and appropriate transportation for themselves, for those who care for them, and any medical equipment necessary for their well-being. The failure to include persons with disabilities in the world's efforts to reduce the risks of disasters has dramatic consequences. Due to inaccessible disaster preparedness plans, systemic discrimination, and widespread poverty, persons with disabilities are often left behind in relief and response efforts. According to World Health Organization, around 1.3 billion people, 1 in 6 people worldwide, experience significant disability. As per under 2013 report, 71% of persons with disabilities do not have an individual preparedness plan for disasters, and 13% of persons with disabilities have no one to help them to evacuate. About 85% of persons living with disabilities have not participated in community disaster management and risk reduction processes in their communities. In such grim situation, the team of IIHMR Delhi students took this challenge to sensitize and train the children with disability towards disaster preparedness. They used innovative, interactive, and creative methods to meet their objective. The team, led by Mr. Shivang Bhama, reached the Little Heart Special School at Krishna Nagar, New Delhi. This school caters to children with mental retardation, cerebral palsy, autism, locomotor disability, learning disability, and multiple disorders. Due to special needs and challenges with these children, fun learning and learning by doing approach was used to make them learn and understand the idea of disaster preparedness. Children were divided into teams and shown pictures related to flood, earthquake, fire, and other natural hazards to bring in the concept of natural hazards surrounding them. During the course of activity, it was realized that children need to understand basic planning and organizing skills in their life for survival during a crisis situation. The concepts and skills related to disaster risk reduction needs to be included in the curriculum, and teaching methods need to adapt to the changing needs. Various instinctive and natural response related stimulus were used to make the children understand and learn the basic concepts of hiding under the table in the event of disaster. For instance, when even after multiple inputs the child was not able to perform the hide under the table activity, therefore he was lured using a food item to achieve the outcome, and later the food item was withdrawn when he learned the concept. In the similar way, students with other types of physical or mental disability were approached to achieve the desired outcome. It was also realized that one method did not work with all the children, and a combination of innovative and creative methods were used for specific situations. This entire sensitization activity is a part of youth-led disaster risk reduction program in line with the theme Fighting Inequalities for a Resilient Future given by the United Nations for the year 2023 for its International Disaster Risk Reduction Program. This event strongly emphasized the role of youth and its importance in driving the international agenda of disaster resilient future and bridging the gap with marginalized and vulnerable population, including persons with disability.
So this is one of the presentations. In the similar line we did for refugee camp, the kids living there, and the Dipali Foundation, which was, this is just a glimpse of the thing, which caters to the slum, children living in slum conditions and studying in a school, NGO school, which NGO run school, which imparts them education for their, basic, so that they can be at least vocationally trained or have basic understanding of the concepts, etc. So that is how we can take the matter forward. I can share the presentation in these videos in the chat box for consumption of everyone. Because of paucity of time, I'm not running these videos right now. So besides that, what we are doing, we are looking forward to have interventions at various levels. For example, at governance, advocacy, policy making, multi-sectoral approach and coordination between academia, between the funding agencies, between the development partners, and things like that. So that we can have health system resilience and response accordingly for catering to the uplifted needs at the time of disaster, and bring in community resilience. For all these things, at some or the other point, we realize that participation of children, be them from marginalized group or from the normal group, both are very important, and it's non-negotiable that we can sit in the room and make a plan for children without involving them. That is just not on. We should not go about that. So we gathered some take home messages from this entire activity, as well as the ongoing programs nationally and internationally, and which we believe that there is a requirement of strong coordination among government and partners required for having this program actively being pursued, being prepared, being delivered, and it should reach the last person. And sustainable funding and strategic planning is required to help cater to the children's need. Capacity building on the ground and engaging the affected community is something which has to be on the cards, and which has to be taken up very seriously. Until we engage the community members, irrespective of their level of participation, we cannot really reach the milestones. And the provider's side, adequacy of supplies has to be maintained, without which it is ineffective at all level until we have adequacy of supplies, continuity of the programs, continuity of the trainings, continuity of the research against the programs that are being run, the effective monitoring and evaluation of the programs. For this, only joint and collaborative actions can be weaved around all these things. One person, one team, one agency cannot really deliver all these effects together. To bring my presentation to an end, I have actually taken the messages from the youth volunteers or the young volunteers of DRR program, and which actually moved me a lot. So that is why I thought we should share it in the platform. While the young research scholars or young researchers and these students were in the field delivering the DRR activity, preparing for them, executing them, and coming back to the campus, they had a set of emotional charge, a set of feelings, a set of understanding of the system, and these are the words that they have shared with me. Somebody who worked with the persons with disability group said that there is ability in disability. All we need to do is find that one ability to make the individual understand his participation and the need in the community. Another person said that planning and delivering the DRR activity was a rewarding experience for him, knowing we were making a positive impact on our community. Somebody who worked with the transgender group and imparted the DRR knowledge to them and sensitization to them believed that transgender communities are having a very high risk index due to individual level disasters every time which surrounds them, which they face daily, and there is a long way to go for this particular community. So this is very true for the transgender group. Somebody who worked in the refugee camp group, delivered the sensitization program there, felt a range of emotions, including empathy, compassion, sometimes even hope. And the experience is both eye-opening and emotionally impactful for that group of participants, for the students. Somebody said it was moving and thought-provoking performance, igniting social awareness and inspiring positive changes. So these are the words which I got to hear from the deliverers or the providers of the program. Somebody who worked with slum children group said that the experience was overwhelming, and as we could see our audience, the little children not only helped us in conducting the program but enjoyed it to the fullest. So children participation was wholeheartedly accepted and understood by these young professionals who are going to be in the field and who are going to become decision makers in the future. Somebody who actually organized the logistics for this entire program believed that planning and organizing the DRR event as logistics manager helped me understand forecasting, planning, organizing, and crisis management part of an event of this scale. Logistics team. So it helped build understanding, deep diving into the issue, taking the crux out of it, delivering it to the underprivileged, vulnerable groups, and bringing about the change, bringing about the impact in the society that was actually not taught in the class but actually was done hands-on by the team. So this is something which I could gather from this event, and I'm very proud that students did it well, and I hope we can make some impact to the lives of the vulnerable group, and we can make this a rolling stone effect with the help of NIDM and partners like CRY and other like-minded institutions. So thank you so much. Last results that I can expect from this is a youth-led, child-centric disaster risk reduction on a rolling stone effect for betterment of the society. Thank you so much. Open to the questions if you have any.
Thank you, Nirgi ma'am. And Dolphy, are you here? Dolphy?
So yes, sir, I am here. Just a moment. Right. Just a moment. Yes. So right. So there is some problem with my internet. Can you please take over, Ranjan ji? There is some fluctuation with my internet connectivity.
Okay. So
No.
Thank you, Nidhi ma'am. Very wonderful and very informative presentation presented by you. And now next session start with Pooja Priyamda ma'am. Actually, I have no CV of Pooja ma'am. You have CV, Dolphy. You can explain.
Thank you, Ranjanji and team NIDM for having me here. Would love to hear Pooja ji for the next session.
Right.
Yeah.
Yes. Now it's better. Ranjan ji, am I audible?
Yes, you are audible.
Okay, right. Thank you. And sorry for that issue with the internet. And yes, so thank you so much, Dr. Nidhi, and thank you for the wonderful, showcasing of your entire experience and your findings. And I can see a lot of your students, they have been, sending us all the remarks and writing about their experiences. So thank you so much. So now I would like to, move on to the next session with Miss Pooja Priyambada, who has joined us here. Right. So before I start with ma'am, let me just give a brief introduction. Ma'am, Pooja ma'am has been associated with Child-Centric Disaster Risk Reduction Center of NIDM for the past few years, and during COVID we held a lot of informatory and awareness webinars on mental health and gender considerations in DRR. So she is one of the best people to be speaking on this joint celebration of all the three observance days. And she's an author, columnist, translator, content and language consultant, and a poet. Currently, she is the academic director at International Institute of Mass Media, Delhi. She is a course facilitator of an online course, Leadership and Management in Health, offered by University of Washington. She's also part of the organizing team of Kritya International Poetry Festival and has been organizing theatre and reading workshops. And so, if I keep on talking about her work profile and her achievements, so we'll never hear the end of it. So I would now, uh, welcome Pooja ma'am to the platform and request her to engage the participants as she deems fit with her topic. So over to you, ma'am.
Thank you. I hope I'm audible there.
Ma'am, your volume is very, very low.
Okay, let me just check it. From my end, it is optimum. Would be optimum. Is it okay now?
Yes, ma'am, it's fine.
Yes, ma'am.
All right. So I'm glad to be back here with NIDM and especially CCDRR. And as Dolphy said, it has been a very productive association for the last few years. Uh, it is very difficult to be the last speaker on the board because almost everybody has touched upon all the other topics. So I have a very brief presentation where I focus on gender and mental health, which have been my two key areas. Since we are celebrating World Mental Health Day today, and we are also celebrating International Day of the Girl Child and also disaster risk reduction. So integrating the three, and I also have some observations to make from whatever was said earlier. So first of all, I will briefly share this presentation of mine, which is, okay, so yeah. So, let me see. Is it visible?
Yes, ma'am.
Yeah, so we are talking about gender and mental health. Now, if you see that screen there, that is not something that is expected of me. I do not adhere to traditional images of women, but that image has a role. And that image I have taken deliberately for the cover slide. So I would request everybody to remember that image as we proceed. I will be talking largely about gender and mental health, but I will also be talking about various intersections that are there, right? Now, first and foremost, let us talk about the content here, which will also mention suicide. And as a counselor, I must tell you that if anybody feels distressed by the mention of suicide, they must leave and come back or have a glass of water, because I do understand this can be distressful. So what are the peculiarities of women in mental health? I know, as a lot of people said, that, disaster does not have a gender. Yeah, that is true. Disaster does not have a gender. But yes, there are segments, marginalized segments that get affected more by gender. Women get affected more because they are the primary parents, and as we were talking about children a lot, so it is women who are doing most of the caregiving for children. They are often also the caregivers for not just children, but the entire household, the family. Uh, they are the ones who go through a lot of reproductive health upheaval. I remember clearly I was working with a lot of groups during the pandemic, and if you remember the workers, the families that were walking on road to go back to their villages, one thing that came into notice quite late was that these women needed sanitary supplies. They needed sanitary napkins. They needed toilets. Those were not given to them. So mental health for women gets affected by a lot of these other factors. And then we have social discrimination, of course, which is gender-related discrimination. In India, dowries, single women are, also, discriminated against. There is sexual violence in all age groups and eating disorders. I do not know how many of you know, but it is women who are affected the most. Blame Instagram, blame whatever. The young generation, of course, as Nidhi said, is doing commendable work in both, mental health and disaster risk reduction. But they are also the ones who are most vulnerable to these new pressures that did not exist, say, 10 years ago. So to look good on social media, to do everything and anything from a point of view to be presented, and that affects their own mental health as well as the mental health of the people they are dealing with. So mental health is then a very crucial aspect of the life of women and children, and particularly when they are in the face of a disaster, whether it is a man-made disaster like the war or it is a natural disaster. Again, women's mental health, I do not think I need to deliberate more upon, but there is this one facet that I want to bring to light, that we often relate deaths by suicide to mental illnesses. But the fact about our country is that the two largest groups who die by suicide are farmers. In the pandemic, it was the workers. And the second largest groups has been housewives. And the number in 2020 grew from to 51.5% from 50.3%. So the women that you see in ads, the glorified Indian ma, is actually the woman who's living under a lot of psychological distress. And these are the women dying by suicides. And these are the women who probably in a disaster situation will not be able to cope up. I was mentoring a mental health helpline, and trust you me, half of the calls from women were not mental health related. They were related to issues like sexual violence in the family, or economic distress in the family, or children going through COVID. So a lot of secondary stress is there for women, and that makes them the most vulnerable population when it comes to mental health. And of course, as Nidhi and others have, Aditi probably has mentioned earlier, that because children are dependent on adults, and most often these adults are women, that distress gets transferred on to children as well. Again, we are talking about girls, International Day of Girl Child. We think child marriages now are a thing of the past. There are 223 million child brides in India, only in India. And a lot of them then go through unsafe pregnancies, unsafe deliveries, unsafe abortions. In COVID, only 2.5 million child marriages were expected to happen. A lot of them go unreported, of course, we know. There is, of course, another aspect to this whole child marriage scenario, and why girl children are more, vulnerable, because child brides are the most trafficked population, especially in northern states of this country, where the sex ratio is so disproportionate, and brides are actually being bought like products and cattle from the poorer states.
हमारा लग तो रहा है, ये फोटो डाल रहे हैं सब व्हाट्सएप पे।
स्पीकर म्यूट किए हो, बंद कैसे हो रहा है?
हमने कुछ नहीं किया।
Yeah, so I'll get back. So child brides are the most vulnerable population because they are being trafficked for marriage, for sex work, and for even organ trade. Then we go on to the digital divide. How many of us talk about this? Whether it is access to handsets, whether it is access to the internet, infrastructure, cyber literacy, online safety. In fact, during the COVID, we had a lot of deaths by suicides of young people between 17 to 19 who were students, and this was due to the digital, access was not there for them for their classes in schools, and a large majority of them were girls. Now, if there is one phone in the family for the children, who do you think will it go to? In a country like India, most probably to the son and not to the daughter. And when there is no internet, then the girl has no information, she has no opportunity, she has nowhere to ask for help, for training, for guidance. Again, when we talk about intersections, so other intersections, like we are talking about humanitarian crisis. Now, are our humanitarian crises and our responses to them, are they intersectional? Do we talk about girls with disabilities? Do we talk about Dalit girls, tribal girls, girls with psychosocial disabilities? And I must make a point, the students IIHMR are doing commendable work, but I heard the term mental retardation mentioned somewhere. Please don't use that term. It is a very insensitive term. The right term for those children is children living with developmental disabilities. So we have stopped using mental retardation. It is a severe term. Also, it is important that we use a lot of, new ways to, for instance, what you were doing for youth-led DRR, and you did it with theater and Nukkad Natak and all of that, and it looks very nice. I also do a lot of theater of oppressed in medical colleges and outside of it, poetry, literature, music. But what is most important is to make it accessible. What language are we using? How many of us know sign language? Children probably in that particular school were not able to grasp a lot of protocols that were being explained to them about earthquake emergency, because we do not have a volunteer who knows sign language. So those are the problems of access that also become a mental health challenge, that also become a disaster risk reduction challenge in this country. Also, another thing, a lot of you know talked about emotional care and first aid. Has anybody here heard about mental health first aid? If yes, you can type yes in your chat window and I will know. There are two kinds of first aids that we have: mental health first aid and psychological first aid. If you know about these two and you know what they are, please type in the chat box or raise your hand. Yeah, so when I went to Johns Hopkins to do my psychological first aid course, surprisingly, in India, from India, they did not have any student. We do not talk about psychological first aid. Psychological first aid is what we need to give people in the eye of a disaster, immediately after a disaster. And it is a very specific, different protocol. And then we have mental health first aid, which is an ongoing first aid, which continues through the process of their rehabilitation and resilience building. So we have to start there, along with first aid, which is physical. We have to inculcate mental health first aid in institutions. Today, in my organization here, we teach media students. So we had a listening circle, and where I did give my students a few tools on mental health first aid, because they are the ones who will be your TV reporters, journalists, filmmakers, and they need to be sensitive on how they report and what they report. And if they are in the eye of a disaster, then they know how to speak to a person, what to say and what not to say, and how to convey the right information. Again, talking about mental illnesses and stress, we all know that it leads to a lot of physical issues. How do you identify a mental illness? I put this slide because this a lot of people ask and are interested in. So one is that if you have persistent sadness or feelings of hopelessness, more than say 60 days, if there is continuous use of any addictive substance, if there is change in your eating or sleeping habits, appetite, weight changes, fatigue is there, you're worrying a lot, you're fearing a lot, you are hearing things and seeing things that are not there, your mood fluctuations are extreme, there are digestive issues happening, strange headaches and aches without a reason, there is irritability, you don't want to socialize, and sometimes you want to kill yourself. Those are some of the commonest indications that this person is in distress. But unfortunately for women, these are termed as, oh, PMS hoga. Oh, it is related to her pregnancy. Oh, she is always irritable with the children. So it is never ever taken seriously, and it often then becomes serious. Moving on, what can be done? I've kept this presentation very, very precise because I want it to be more interactive and I want to listen and answer. So women, what they can do for themselves is look after themselves, so have a self-care routine. Women, social media especially, I often ask my students how many hours of screen you do. So screen has become a major factor that is leading to a lot of mental health distress. We must learn to delegate responsibility, which is very, very important, which I think was talked about earlier also, that the Mental Health Care Act 2017, trust you me, it took us a decade of activism to get it on paper and get it done. And still we are fighting with newspapers and media houses to just remove the word committed suicide. It should be died by suicide. So just that has taken so long, but it is a good move that CRY is bringing in this deliberation to make the Healthcare Act child-centric. Of course, there has to be autonomy for children, but they're coming from, our disability discourse that nothing about us has to be without us. But again, it has to be coming from a point of being the children being informed. If the children are not informed, then it will be very difficult for them to be part of any deliberation that leads to legislation that affects them. So children need to be self-reliant. They need to have age-appropriate information for themselves, and that probably will go a long way in making it safer, mental health-wise, in any disaster situation for everybody, including women and girls. Next up, I just had this last slide, which has given you two numbers, which are helpline numbers for mental health helplines. And often, this is the most common excuse that is given in India, definitely, and a lot of South Asia, that if women are looking after themselves, they're selfish. Mothers are supposed to be selfless and they're supposed to give everything away for children and family and not look after their own health and not care after their own health. So those are a few issues that we need to, kind of address, and women and girls need to prioritize their own health. Similarly, in disaster risk reduction, since they are the most vulnerable group, they need to be talked about. I was talking about intersections. So coming to intersections, I saw in the comments, somebody talked about the transgender community and how disaster risk reduction was done with them. If you see, my profile name here contains my pronouns, she and her. A good beginning for everybody to be sensitive to queer people, to be sensitive to the LGBTQIA people, would be to start using your pronouns along with your name when you appear officially somewhere. These are little things that go a long way in making everything we do intersectional and integrational. Also, I would like to tell you that, a lot of things here have been covered, but there is a lot to do, and that lot has to come after a lot of deliberation of all these stakeholders, but most importantly, the people who are most affected by it. Somebody did mention toilets in schools. Yes, it is a major factor. It is also about safety. For instance, in places where there is no public transport to reach schools, girls often do not go to high school because there is no safe transport to go to high school. So these are small practical issues that keep them away from education and awareness, one, but again cause a lot of distress to them and could lead to a lot of mental health distress to them as well. Now, before I close, I would like all of you to put one word in the chat box that you associate with disaster. One word. It could be any word. This is a small activity. So I would want each one of you to put one word in the chat box that comes to your mind when you hear the word disability. Sorry, disaster. Anybody? I don't see any words coming up. For disaster, any first word that comes to your mind? Empathy, all right. Risk and vulnerability, very nice. Okay. Pathetic situation, all right. Okay. Quick danger, suffering people, trauma. Any more? Any more coming in? Danger, yes. Unprepared situation, uncertainty, hazard, wonderful. Okay, so now when you map these words, you will realize risk, calamity, stress, hazard, uncertainty, damage to public infrastructure, mental health of children, wonderful. Okay, so when you see most of these words, prevention is better than, yeah. So either when I do this exercise in any such group, secure place, hazard, mental health, either the words are preparatory, that how to prepare for a disaster, or the words are reactionary or responsive. You know, what is our reaction or response to the disaster? Uh, the middle part, you know, where the disaster is actually happening, what we call the eye of the disaster. There is often little focus on it. Some gentleman was writing about no ramps in a lot of educational places, which is true. Fire safety is a huge problem in most of our schools and educational places. It is often not adhered to. Uh, Students don't even know where the fire exits are. Often the equipment that is there is outdated. Women, of course, are probably the last ones who have access. I still know a lot of women who, in Delhi, right here where I am, do not have access to a clean toilet at their workplaces. And of course, the psychological first aid part, that if at all there is a disaster, is there a system in place to offer them psychological first aid? If you remember, our students were stranded in Ukraine. Indian students were stranded during the Ukraine war. They were there. And we all, a few of us, mental health activists, we connected to them over call, and they were listened to, and they were calmed down, and they were pacified. And I think as important as it is to see those pictures of them on a plane coming back to their homeland, which is physical rescue, and as important it is to ensure that they have food and shelter and they are safe, there is no focus even in our media or how these events are covered or how we see them. None of them, none of you probably as an audience cared that were these people, were these students from Ukraine being airlifted, given any kind of psychological first aid. So there lies the problem. There lies the key issue, that the psychological first aid part, the ongoing mental health support part, is often not integrated into our disaster responses and into our disaster risk reduction responses. And because women and girls are a margin, so if at all something like this happens, they again stand at the end of the queue in such situations. And that is what we need to address. So with that, I will close my sermon and I will take questions if any. Thank you so much for having me over today.
Thank you, ma'am.
Am I audible?
Yes.
Yeah, you are.
And thank you so much, ma'am. And thank you so much for, keeping it very, very interactive. I can see a lot of comments here, and we will definitely be saving. There are so many comments, we might not be able to go through all of them, but we will be saving all of these comments and keeping them as part of our report and put that in the public domain, right?
Yes.
So do we have like 5 or 10 minutes to just like take a few questions? Can we do that?
Yeah, sure. Sure.
Yeah, Pooja ma'am has done a few of them already, but let me just see if we, wow, we have such an overwhelming response from the students sharing their experiences. So this is like
Yeah.
something that we have never seen in any webinar.
Yeah.
So
Also,
I think
I would like to address this. This gentleman has been talking about fire safety. So yes, as parents, as teachers, we care a lot about educational institutions. We check in their PGs कि वहाँ पानी है कि नहीं, toilet है कि नहीं. Lot of things we do check. AC चलता है कि नहीं, बिजली है कि नहीं. But have you heard anybody probably, check in a hotel or go to a PG or go to a student hostel and ask कि यहाँ fire safety है या नहीं? We don't ask that. It is so low on priority. And that is the problem. That is what needs to be addressed.
And that is
Yes,
why
yes, ma'am.
we are organizing such talks, that the common sense of the people should be aggravated and ignited towards the safety first.
Yeah.
We are the people, we used to wear helmet while driving bikes,
Yeah.
wearing the seat belts while driving cars,
Yeah.
only to save us from paying penalty to the traffic police, not understanding that it's for our safety and security and we have to do it on our own.
Yeah.
So that is
Right.
the reason.
Us-
Perfectly all right. Thank you very much, Pooja, for very enlightening talk on the mental health. Go ahead, Dolphy, with the
Right.
questions. Yeah.
Yes, sir. So I think a lot of the questions have been answered through through both the presentations. There is one question which I think is a very hard hitting and like a very important question that we need more of discussion on. So I would want to present that question first. So a participant named Ashokan has written that all of the time we present and discuss all of these issues and problems, but still the vulnerability community lives the same. Much of nothing, goes nothing goes into making their lives better, especially their day-to-day life. So this is a remark. So maybe we can, have a discussion on this, because a lot of people, they feel this kind of disenchantment when we talk about any, anything with respect to betterment or when we talk about any collective solution. A lot of the people, especially the economically weaker section and the marginalized people, they have this disenchantment that nothing ever gets done. Even if when somebody comes to their community, they will take some pictures, do some initiatives, and then disappear, and nothing long term will happen that will change their lives, their day-to-day lives for better. So maybe the speakers can address.
Yeah, so you see, resilience building is an ongoing process. So I'll give you one example. So I have translated this book for the caregivers of children with Down syndrome. We had to do this because the children, the parents were willing to be caregivers, wanted to learn how to look after these children with a particular disability, but there was no information. The information available was in English, and most of these parents were not able to read English. So when that book was translated by an NGO and distributed to these parents of children with Down syndrome, it became a very useful tool because उसमें सब कुछ था. उससे बात कैसे करें, स्पीच थेरेपी में क्या होगा, काउंसलर से क्या सवाल पूछें, थेरेपिस्ट से कैसे बात करें, कहाँ पे हेल्पलाइन पे फोन करें, कौन से डॉक्टर को दिखाना है, कौन सा दवाई खाना है. जब ये बात उनकी भाषा में की जाएगी और उनको एनेबल करेगी कि हर काम के लिए, हर छोटी बात के लिए, दे डोंट हैव टू कम टू अस और यू और एन एनजीओ, बट दे हैव रेडी इंफॉर्मेशन विद देम, then it becomes more effective. If we keep control of all the information, as a translator, I keep saying this, we need more and more information about disasters management, about mental health, about rescue and relief, theaters, plays, poetry, everything, but not in English, not in our big cities, in smaller places, in their regional languages, in their places that are far to reach. If it becomes that, then it will stay with them.
Thank you, Pooja ma'am. And the same question to Dr. Nidhi, because she has recently, worked with vulnerable communities and especially vulnerable children. So ma'am, what is your take on
That is
this?
what I wanted to tell, that it's what is actually the question. Uh, the reply is already in your chat box. It's not something is static. A lot of Dr. Nidhi, go ahead with that. We can see the students, they have taken a lot of efforts. They are doing wonderful things.
But
And
sir, one of the students only has asked about the translation of efforts into real change. So the question is
yeah,
that.
let Dr. Nidhi
Yes,
take
sir.
it, and after
Right,
that.
right.
जी, एक्चुअली मुझे मेरा आंसर इस क्वेश्चन के लिए मुझे लगता है हिंदी में देना चाहिए, जो पूजा जी ने भी बोला। हमारे ऑडियंस के लिए हमें सिर्फ एक भाषा का प्रयोग करते हुए अपने क्वेश्चंस, अपने आंसर्स, अपने संवाद या अपनी अप्रोच को नहीं रखना चाहिए। तो मैं इस बात की स्ट्रॉन्ग बिलीवर हूँ कि हम जो भी कार्यक्रम, जो भी पॉलिसीज, जो भी प्रोविजंस, जो भी एक्टिविटीज करें, एक तो वो मल्टीलिंग्विस्टिक हो, वो रिटन मटेरियल हो सकता है, वो डिस्कशंस हो सकते हैं, वो प्रोग्राम्स हो सकते हैं, वो इवेंट्स हो सकते हैं जो हम सोसाइटी में जाके कर रहे हैं। तो वो मल्टीलिंग्विस्टिक अप्रोच हमें रखनी पड़ेगी, और हमेशा केवल इंग्लिश को ही एक भाषा या एक माध्यम कम्युनिकेशन का मान के अगर हम स्टिक हो जाएंगे, वो कभी पूरी तरह से हमारे पर्पस को सॉल्व नहीं कर पाएगा। हमें जो हमारा उद्देश्य है उसे मीट नहीं कर पाएंगे हम। हमारे इस प्रोग्राम के एग्जाम्पल से मैं समझाना चाहूंगी, जो स्टूडेंट्स ने किया, तो जो भी प्रोग्राम सोसाइटी में जाके किए, जो भी प्रोग्राम लोकल पीपल के साथ किए, रिक्शे वाला, ऑटो वाला, स्लम चिल्ड्रन, या एक्सेप्ट फॉर द इंस्टीट्यूशनल सेटिंग्स जहाँ पे क्लोज्ड एनवायरमेंट्स थे, ग्रेजुएट स्टूडेंट्स हैं वो थे, इवन वहां पर भी बाइलिंगुअल मेथड यूज किया गया कि वही चीज आप वही बात भाषा बदल के दूसरी भाषा का इस्तेमाल करके वर्नाकुलर लैंग्वेज, वर्नाकुलर टर्म्स यूज करके भी समझाएं। क्योंकि हर बार आपदा नहीं बोला जाएगा, हर बार प्रबंधन नहीं बोला जाएगा, हर बार डिजास्टर मैनेजमेंट नहीं बोला जाएगा। उसको वर्नाकुलर लैंग्वेज में कि अगर ऐसी कुछ क्षति पहुंची है, इस प्रकार की नुकसान पहुंचा है, इस प्रकार की समस्या आई है, तो उसको जूझने के लिए हमें क्या करना है, उससे झेलने के लिए हमें क्या करना है, उसे संभालने के लिए हमें क्या करना है। तो सेम चीज को जब आप मल्टीपल तरीकों से बताते हैं, तो वो डिफरेंट डिफरेंट, दिल्ली में बड़े सारे वर्नाकुलर ग्रुप्स है, वर्नाकुलर लैंग्वेजेस के यूज होते हैं, तो उसको समझाने का हमने कोशिश किया। और मुझे इसमें इस बात को एडमिट करते हुए बहुत प्राउड फील हो रहा है कि स्टूडेंट्स जब अपनी बात समझा के आए, तो दे एक्चुअली केम आउट विद द थिंग कि हम तो ये स्क्रिप्ट इंग्लिश में लिख के ले गए थे। जब उनका स्क्रिप्ट का क्वालिटी कंट्रोल हुआ यहाँ पर, तो स्क्रिप्ट उन्होंने इंग्लिश में बनाई थी, पर डिलीवरी का माध्यम जो उन्होंने पाया वहां पे वो हिंदी को इफेक्टिव पाया, वो उनकी लोकल लैंग्वेज, और हिंदी भी वो वाली नहीं जो गूगल ट्रांसलेट से हम कर लेते हैं, गूगल के माध्यम से हम कन्वर्ट करा लेते हैं, वो हिंदी जो हम आपस में बातचीत करते हैं, और वो लोकल लैंग्वेज में लोकल बात करने के तरीके से बहुत अच्छे से समझ आई। और ये कम्युनिटी ने उनको रिस्पॉन्स दिया कि आप जो बताने आए थे उसी सरल भाषा में उन्हें समझाया। सो आई थिंक ये जो हम बात कर रहे हैं, ये अल्टीमेटली उसी तरफ इशारा करती है कि जो भी हमारा माध्यम हो वो हमारे टारगेट ऑडियंस को ध्यान में रख के बनाया जाए, ना कि मैं क्या सोचती हूँ, मेरी टीम क्या सोचती है, ऑर्गेनाइजेशन क्या सोचती है, उस प्रकार से। सो आई कंप्लीटली अग्री, पूरी तरह से मैं सहमत हूँ इस बात से, और हमारे ग्रुप्स इस बात को लिख भी रहे हैं। डॉक्टर पूजा ने भी ये बात बोली, डॉक्टर राका ने भी ये बात बोली। सो it has to translate and get down to the thing which is acceptable, understood by the community.
Actually, we all are doing this thing, and मतलब पहले जहाँ डिजास्टर मैनेजमेंट एक टाइम में था और आज का डिजास्टर मैनेजमेंट, पहले जो मटेरियल्स थे, अभी जो मटेरियल्स हैं, पहले जो मॉड्यूल्स थे ट्रेनिंग के, वो कितनी भाषाओं में ट्रांसलेटेड हो गए हैं। एंड देखिए, इसमें भी मैं वर्नाकुलर लैंग्वेज का टोटली सपोर्टर हूँ, बट हमें प्लेटफॉर्म देखना पड़ता है, व्हाट टाइप ऑफ प्लेटफॉर्म वी आर टॉकिंग अबाउट।
Yeah.
Suppose that I am going to Tamil Nadu and I am speaking in Hindi, then it doesn't solve my purpose, not at all. So normally ये जो online platforms होते हैं, ये all over India के लिए खुले होते हैं. It's for participating, for anyone from Delhi, anyone from Kerala, Tamil Nadu, Andhra Pradesh, everyone is joining. So better we prefer the English language here,
Yeah.
on this national
Absolutely.
platforms.
Absolutely.
But definitely NIDM is into translating, CRY के साथ, Save the Children के साथ मिलकर के हम लोगों ने वर्नाकुलर लैंग्वेजेस में भी अपने मॉड्यूल्स को, अपने प्रेजेंटेशंस को ट्रांसलेट किया, एंड एज पर द रिक्वायरमेंट ऑफ द ऑडियंस वी प्रेफर
Yeah.
है कि पहुंचाना है। जो बातचीत हो रही है वो जब तक पार्टिसिपेंट के पास पहुंचे ही नहीं, तब तक आप कोई भी भाषा इस्तेमाल कर लो, उसका कोई मतलब नहीं होता।
Yeah. Also, I believe disaster में sign language is very important.
Yes, yes,
क्योंकि कोई दबा पड़ा है कहीं, तो वो शायद बोल नहीं पाएगा, लेकिन वो इशारे से समझा पाएगा।
बिल्कुल पूजा, वी आर
साइन लैंग्वेज इज वेरी वेरी इंपॉर्टेंट।
सिर्फ इंजरीज के लिए ही नहीं, डिजास्टर मैनेजमेंट में एक अंधे को कैसे, एक ब्लाइंड पर्सन को कैसे पता
हाँ,
चलेगा कि कुछ गड़बड़ हो रहा है, क्या करना है? सो वी आर वर्किंग फॉर दैट एज
yeah,
वेल। आपका जो है हैंडीकैप इंटरनेशनल के साथ हम लोग साइन लैंग्वेजेस में एटलीस्ट डूज एंड डू नॉट्स जो होते हैं डिजास्टर्स में, उसको
yeah,
लेकर के आने की कोशिश कर रहे हैं। सो अ लॉट ऑफ थिंग्स, प्रोग्रेस तो बहुत कुछ हुआ है, बट स्टिल गैप्स एंड गैप्स हैं, तभी हम लोग डिस्कस कर रहे हैं एज सिंपल एज
absolutely.
दैट।
Yeah.
या
Right. Yes. So there are a few more questions, but most of them have been answered through the एक किसी ने पूछा हुआ intersection between all the 3 days. So I think we started with that particular. तो अगर आपने मिस कर दिया है, आप YouTube पे जाके आप देख सकते हैं, पोस्टर में हमारा YouTube का लिंक है, and you can go and check the YouTube चैनल है NIDM का। आप इसी टॉपिक को डालेंगे वहां पे, आपको वो मिल जाएगा, पूरा का पूरा सेशन आपको वहां पे मिल जाएगा YouTube पे, एंड आप वो देख सकते हैं। तो लॉट ऑफ क्वेश्चन
एक
मोस्ट
क्वेश्चन पहले आया हुआ था जो कि काफी पीछे चला गया होगा। आई थिंक सम, आई डोंट रिमेम्बर द नेम ऑफ द पार्टिसिपेंट हु आस्क्ड इट। ही वाज आस्किंग दैट व्हेन वी वर डिस्कसिंग अबाउट चाइल्ड मैरिज, कि हम लोग कम्युनिटी के स्तर पे भी कुछ काम करते हैं। इफ़ वी आर डूइंग समथिंग एंड वी आर स्टॉपिंग चाइल्ड मैरिजेस, देन द कम्युनिटी इटसेल्फ एंड द फैमिली इटसेल्फ गोज अगेंस्ट अस। एंड वहाँ पे गांव के जो सरपंच होते हैं और द मतलब आई मीन टू से जो ताकतवर लोग होते हैं वो भी उसके फेवर में आ जाते हैं। एंड फाइनली पुलिस वालों को भी इन्फॉर्म किया जाता है तो वो भी उन्हीं लोगों का साथ देते हैं। बट दैट इज अ रियल चैलेंज ऑन द ग्राउंड। सो हाउ आवर एक्सपर्ट्स आर लुकिंग ऑन टू दैट, what to do about it?
So I would say, because I come as a media educator here, media has a huge role to play. You have to bring
Yeah,
media
that question
intervention.
was asked by Chandrasekhar.
Yeah, Chandrasekhar ji. So media has to be brought into that. जब मीडिया आता है और कैमरा लेके हम जाते हैं, तो बहुत सारी चीजें पुलिस और नेता और जो ये आपने कहा छुटभैया नेता लोग जो वहाँ बुली करते हैं या अपना तरीके से मैनिपुलेट करना चाहते हैं, वो कर नहीं पाते। और मीडिया का इसलिए बहुत महत्वपूर्ण रोल है। तो आप मीडिया को लेके आए, आप ऐसी बहुत सारी ऑर्गेनाइजेशन है, अकेले कई बार फॉर एन एक्टिविस्ट सेफ नहीं होता है ऐसे एनवायरमेंट से रिपोर्ट करना। So it will be good if you can take an organization support who works in this area and then connect with the media, with the local media, who definitely will have, I'm sure media में भी उसका किसी का influence रहेगा ही, and there will be people who will be siding with the other person, but there will always be also people who will support the cause and who will probably put your voice on a national platform and get you more support. So please include media in such cases.
And along with that also एरिया का जो डिस्ट्रिक्ट CDPO चाइल्ड प्रोटेक्शन ऑफिसर जो होते हैं
Yes.
उनको आप इन्फॉर्म करें तो सो दे विल टेक केयर ऑफ दैट। देयर आर वेरी स्ट्रिंजेंट लॉज रिगार्डिंग चाइल्ड मैरिजेस
Yeah.
and it will not go unnoticed if the proper stakeholders are involved into that.
Yeah, absolutely.
Thank you so much, sir. And I think we can take one more question if that's okay.
Yeah.
Right. So somebody has asked about how to handle a patient suffering from PTSD after a disaster. How do we manage them?
So one thing is that PTSD, again, for people who do not know, it is post-traumatic stress disorder. Now, we have to see this. This is not a simple question. Does this person have PTSD before the disaster, which became worse after the disaster? Or it is PTSD that was triggered by the disaster? Or it is CPTSD, which is seen in patients who often have a mental illness and then they undergo a traumatic experience and then it becomes a PTSD situation. So we have to see it from that angle. A psychological first aider can only give immediate relief. Listen to them, what they want, adhere to their immediate needs, and then probably connect them, as Rakas has said, to the appropriate person next on the what we call the mental health care pyramid. So if you are a psychological first aider, you will just give whatever you can give as a first aider. जैसे physical first aid में होता है, you just give first aid and then you take the person to a doctor. So similarly, you give psychological first aid, and then you connect this person to a psychologist or a psychiatrist, or the Zilla hospital, where there will definitely be a psychiatry department. So whoever is there can probably address this better, because PTSD cannot be addressed in a very simple.
Just to add to it, see, PTSD, like already Dr. Pooja ma'am already told that it's not simply something happened and after that PTSD is occurring. Maybe previously also, the simple thing is that after psychological first aid and initial interventions, if you don't see any improvement in the victim, then don't wait.
Yeah.
PTSD takes enough time to surface first time for the first timers, obviously. First it's disorder and after that it's post-traumatic stress disorder. Normally it takes 2 to 3 months, I think, or something like that. Pooja ma'am, correct me.
Yeah.
But improvement is not there, you don't wait. As simple as that. Immediately go with expert.
Yeah, absolutely. So just like physical first aid, the principle is simple. You give first aid and then you move the person to the next person in hierarchy, which would be a counselor or a psychologist who will probably be able to diagnose. And a psychological first aider is not supposed to diagnose whatever their condition is. You're only supposed to be giving just first aid. The diagnosis can be done later on. There are questions about how to respond to people who cannot speak or hear, and autistic people living with autism and neurotypical individuals. Again, in general also, in everyday also, if we come across a person who has a speech or hearing challenge, how many of us are comfortable communicating with them? That comfort has to be first developed in every day. Only then you'll be comfortable dealing with somebody with a disability in a disaster situation. So it has to be a long drawn process. I am not, I know special schools are doing commendable jobs, but I want our education system to be more integrative, where children with special needs or children with disabilities are integrated into non-disabled classrooms, so that my non-disabled child knows sign language right from class 2 or class 3, so that if there is a disaster in school, these 5 non-disabled children can probably pull that disabled child out. So it has to begin from there. It cannot begin overnight, family.
Definitely.
Thank you so much, ma'am.
Inclusion is always better than exclusion.
Absolutely. Absolutely. That's the principle.
Disability inclusive DRR is also on the cards of the government and it's strongly advocated. So
Yeah, absolutely.
Dolphy, I think time is going beyond our control.
Yes,
So
sir.
we will
Yes,
not
yes,
take
yes.
more questions. Dr. Sahin is still there.
Yes,
So,
right. Yes, sir. So now we come to the end of our program today, and let me please invite Dr. Shaheen Ansari, Education and Emergency Specialist with Child Rights and You, to deliver the closing remarks for the event today. Over to you, Dr. Shaheen.
Thank you, Dolphy. And Professor Nidhi Yadav, Pooja ma'am, Dr. Raka, Dr. Balu, Ranjan ji, and all the participants. Very good evening. This webinar has been really a very good learning. Lots of things which came up during discussion, and uh, this Dr. Raka started with the gender and the disaster, then Aditi, then Nidhi ji, and finally Pooja ma'am. And these are the very important thing. What I learned in this thing is mental health, gender equality, and disaster risk reduction are not isolated issues. These, throughout the session, we could see that these are very interrelated, thing, and it affects each other. Uh, uh, Mental health matters. Gender equality is non-negotiable in any, whether it is during disaster or without disaster or normal days. Gender equality is non-negotiable. Disaster preparedness is shared by responsibility. These are the things which throughout the session I could see. whether it is advocating for mental health services, supporting girls' education and empowerment, or strengthening disaster preparedness in our communities, your action can have a profound impact. Like Dr. Nidhi Yadav shared her experience with her student going to the communities with English literature in hand and then communicating them in the local languages, and how they got two kinds of feedback. One, they are satisfied that okay, they have done something very good, and they themselves empowered with more knowledge. You know. So these are the some important. What other thing like what I heard during the Professor Yadav said that future is in good hand when she was talking about the youth led DRR initiative and how she managed that future is in good hand. And actually, if the youth and children are engaged together to take it forward, we think that future will be in a good hand because we have to tap them right in the beginning from the childhood and the youth. That these are our future, and we need to prioritize action to shape society where mental health is prioritized, girls are empowered, and disaster risk is minimized. These things only come when we will engage with youth, children, and other stakeholders in the community related to disaster risk reduction. CRY, with a strong and long-term collaboration with CCDR in IDM, is targeting this by investing child-centric and gender-sensitive disaster risk reduction. With this note, I think we have got lots of things, and so I like to thank NIDM, uh, uh, Nidhi ji, and Pooja ma'am, and all for this making this evening very thought provocative, knowledgeable for all the participants. Thank you very much.
Thank you, Shahin sir. Thank you
Thank
for
you
the
so
kind
much.
words.
Thank you. एंड थैंक यू सो मच टू एवरीवन. चैट बॉक्स में इतना ज़्यादा अच्छे रिस्पॉन्सेज है, मैंने सारा सेव कर लिया. आई हैव एक्सपोर्टेड द एंटायर चैट बॉक्स and we would be very happy to put that in the report. And thank you so much to all these young students who have put in the effort to write for us in the chat box. And thank you to all the participants for their interaction and questions. And yes, so now may I please invite Mr. Ranjan Kumar from CCDRR to deliver the vote of thanks and wind up today's session.
Thank
Over
you,
to you, Ranjan
Doctor,
ji.
for inviting me as a for vote of thanks. सबसे पहले हम अपने दोनों एक्सपर्ट जो हमारे आज के जैसे स्पीकर थे, बहुत अच्छी तरह से बहुत इंफॉर्मेटिव चीज़ें और ग्राउंड लेवल पर क्या चल रहा है मेंटल हेल्थ से अच्छी तरह से लोगों के बीच में डिस्कशन किया, उसके बारे में बताया लोगों को, और लोगों के एक बहुत अच्छी इंफॉर्मेशन लोगों के बीच में शेयर किया जिससे लोग इस तरह से अपने आप को रेजिलियंट बना सके, अपने आप को प्रिपेयर कर सके. ऑन द बिहाफ ऑफ एनआईडी मैं सबसे पहले मैं अपने एग्जीक्यूटिव डायरेक्टर को धन्यवाद देता हूं कि जिन्होंने इस तरह के वेबिनार आयोजित करने के लिए हमें प्रेरित किया. एंड ऑन द बिहाफ ऑफ एनआईडीएम आई आल्सो thanks to my project director Professor Santosh Kumar, senior program officer Dr. Kumalaka, Balu, Najia, and all CRY team, Science Labs and Dolphy and Aditi, all के कंबाइंड एफर्ट से इस प्रोग्राम को सक्सेस बनाने में मदद मिली है. तो वंस अगेन ऑन द बिहाफ ऑफ एनआईडीएम जितने भी पार्टिसिपेंट आज इस वेबिनार को ज्वाइन किए हैं उनको मैं धन्यवाद देता हूं जिन्होंने अपना कीमती वक्त निकाल कर इस वेबिनार में पार्टिसिपेट किया. इसके अलावा सर्टिफिकेट के बारे में बताना चाहता हूं कि जिन्होंने रजिस्टर नहीं किया है वो आज और कल तक रजिस्टर कर लें जिससे कि सर्टिफिकेट हम जनरेट कर सकें. और जिन सर्टिफिकेट के बारे में ऑलरेडी डिस्कशन हो गई है शुरू में, आपको लिंक दिया गया है आपको चैट बॉक्स में. एनआईडीएम के पोर्टल पर जाकर भी आप इस प्रोग्राम के अंदर रजिस्टर कर सकते हैं अपने आप को. तो मैं एक बार फिर से एनआईडीएम की तरफ से सभी को धन्यवाद देता हूँ. थैंक यू टू ऑल. थैंक यू साइंस सर. थैंक यू.
Thank you, everyone. Thank
Thank you,
you.
Ranjan ji. Thank you, Dolphy.
Thank you
Bye.
so much.
Take care.
Thank you. Thank you all. Thank you so
Thank
much.
you.
Thank you.
Thank you.
डॉल्फी क्लोज कर. थैंक यू अदिति.
हाँ, एक सेकेंड रंजन जी, थोड़े से ना रिमार्क्स रह गए, मैं सेव कर लूँ बस एक सेकेंड. जस्ट अ मोमेंट, लास्ट वाले ना, एक सेकेंड. राइट. So Right. Okay, done, Ranjan ji. You can close the platform.